Healthcare systems, the United States and the United Kingdom. The United States healthcare system boasts availability of modern medical technology. For example, the US has 37.5 MRI scanners per million population versus 7.2 per million in the UK. This illustrates paradox of an excess and deprivation of the US healthcare system, as Bodenheimer and Grumbach quoted. Deprivation is experienced by uninsured and underinsured compared to the care enjoyed by the insured. The United Kingdom has universal health care coverage for all the people, including retirees and immigrants. There is no deprivation. Here, those two healthcare systems are compared for health insurance, medical care, and cost control. Health insurance. The U.S. health system is financed in four basic ways: out-of-pocket, individual private insurance, employment-based group insurance, and government programs. The first three methods allow people access to health care. However, the annual deductible, co-payment, and co-insurance requirements make it financially very difficult for some people. Governmental financing, that is Medicare and Medicaid, enable low-income and high-need people health care access. However, some people are still left uninsured. And even when insured by Medicaid, some people have a hard time getting a provider because some providers don't take Medicaid. This 8.5% uninsured constitute 27.7 million people in the U.S. Community health centers that are federally funded to offer health care to uninsured, still people have a hard time getting appropriate care outside of these clinics and getting drugs they need. The UK healthcare system is mostly financed with tax revenue. Those who can afford private insurance are allowed to purchase private insurance, making about 11% of the population. Those who get private insurance contribute to the National Healthcare Service also. There is no uninsured population in the UK. Nobody is left behind. Another nice thing about the English system is that, as this table indicates, there is no fee for any health service received. Now we will look at medical care provided in each country. Insured people in the U.S. can choose any PCP, not restricted by the region in which they live. Referral to specialists is done by the PCP, or the patient can make self-referral bypassing the PCP. In the UK, citizens can choose their GP or switch GP in the district where they live. Unlike the US, one needs a GP referral for access to specialty care, except in cases of emergency. High-cost medical equipment such as MRI machines are less common in the UK. They also use less expensive drugs. That makes the UK healthcare expenditures less than half of that of the US. However, as Lippi reports, healthcare outcomes are not improved by higher funding. On the other hand, outcomes are improved by better quality of care. Community and public health networks, also funded by the NHS, and nurse-run programs are contributing to successful chronic disease management. Cost control. A currently used cost containment method requires pre-authorization for expensive procedures and medications in the U.S. For HMOs, PCPs play a gatekeeper role for managed care. There are several financial control methods suggested. eliminating ineffective and inappropriate care, using competitive strategies against private insurers to encourage selling better products for less, increasing patient cost sharing, reducing administrative waste, negotiating drug prices, strengthening program for disease prevention and chronic management. The real cost control comes from chronic disease management by lifestyle change. As stated by Friedman et al., nutritionists and exercise physiologists are appropriate professionals who can integrate lifestyle factors into overall higher quality healthcare. The UK, the GP as the gatekeeper, control referral to specialists. The government can limit the NHS budget for cost control, which increases wait time for non-emergency consultations and elective surgeries. Multidisciplinary care by community and public health networks funded by the NHS and nurse-run programs contribute to successful chronic disease management. Conclusion. As Lippi reports, the U.S. spends about $9,900 per capita, and the UK spends about $4,200 per capita for health care. Potential years of life lost, indicated by premature mortality, provides a straightforward means for showing preventable deaths at 4,611 per 100,000 people in the U.S. and 2,296 per 100,000 people in the UK. Thus, health and well-being of these populations are not substantially dependent on the amount of healthcare funding, but it is more influenced by quality of care. As Bodenheimer and Grumbach believe, healthcare is a basic human right, and even more important is having a culture of taking care of each other. As we control healthcare costs for one way or another, everyone in the U.S. should be able to receive healthcare without worrying about financial consequences. Kai et al. Found that there is near consensus that single-payer would reduce health expenditures while providing high-quality insurance to all U.S. residents. To achieve net savings, single-payer plan rely on simplified billing and negotiated drug price reductions, as well as global budgets to control spending growth over time. Replacing private insurance with a public system is expected to achieve lower net healthcare costs. We should move toward a single-payer system to reduce excessive commercialism and ways to cover every single person in the U.S. for better quality of healthcare.